My name is Muneera and I work at Oslo University Hospital. I'm very honored to be invited to this meeting and getting the chance to speak to you. So today I will talk about surgical position of the slim modular electrode. We perform cochlear implant surgery with a slim modular electrode at the intervention center. This center is dedicated for research and development of new methods. The setup at the IVS Center allows intraoperative microscopy, fluoroscopy, ECOG measurements, and cone beam CT. In our view, intraoperative fluoroscopy can be used to control insertion of the slim modular electrode and desired positioning. We have a team that work together that consists of surgeons. So previously Dr. Binne, my very good colleague and mentor who has recently retired. So now it's me and Dr. Jablonski, radiophysicist Ralph and Torkil, and radiologist Hilde. We work together to try to improve our surgical techniques. So why is positioning important and how can it be measured? Previous studies have found a correlation between CI outcomes and intracochlear electrode position factors. There are different radiological imaging techniques and analysis to evaluate intracochlear position of the electrode, and these can be divided into three main categories according to the objective. So looking at the scalar position to see whether the electrode lies in scala tympani or scala vestibuli, the depth of insertion of the electrode, and electrode position regarding the modular wall distance where the spiral ganglion cells lie. So now I will focus on the surgical aspects affecting positioning of the slim modular electrode. And I would like to talk about facial recess opening, proper opening of the round window, insertion angle and depth of electrode array, the sheath removal, packing and coiling. It is important to have an optimal view of the round window through the facial recess for proper insertion angle and alignment of the electrode according to the basal turn of the cochlea. As we know that the temporal bone anatomy varies and facial recess width also varies. One study showed mean width of facial recess at the level of round window to be 2.65 millimeter. In those cases where the facial recess is not properly drilled out, the alignment marker and the sheath assembly may obscure the view. Therefore, extension of the facial recess may be necessary. The recommended cochlear opening is 0.8 to 1 millimeter, and it is advised to use the sizing tool to ensure this. Adequate opening of the round window is important mainly for two reasons: to avoid resistance to sheath and bending of the sheath during insertion, and to orientate electrode array in respect to the plane of the basal turn. If there is still a bony overhang or the opening is not too wide enough, there may be a resistance during insertion, which may cause displacement of the electrode outside the sheath prior to insertion. Here we can see on the top left picture, there's a bony overhang. This caused resistance to the sheath during insertion, which displaced the electrode outside the sheath prior to insertion. So on the right side, two pictures show the electrodes displaced outside the sheath. The electrode was then reinserted back into the sheath. There was done extension of round window, which we can see on the left bottom picture, and the electrode was then reinserted without any resistance. During insertion, the sheath handle should be orientated towards the modalis to align the electrode according to the basal turn of the cochlea, to prevent the electrode going down to the floor or upwards toward the basilar membrane to prevent trauma or translocation. There are three markers proximal to the stimulating contacts which indicate insertion depth. Some studies have shown electrode past the first marker may result in increased electrode to modalis distance and unfavorable positioning. We think that intraoperative fluoroscopy may help to identify the bulging effect of the electrode and immediate interventions such as pullback maneuver. So here we can see intraoperative fluoroscopy pictures, same patient. The first picture on the left side, we can see that the electrode lies more medial to the medial or closer to the modalis. And the second picture here, the electrode is inserted more deeper in, but it moves more to the lateral side in the basal turn of the cochlea, while also a bit deeper inserted. So after pullback maneuver, we can see that electrode seems to lie more proximal to the modalis now, but also keeping its deeper insertion. So for this patient, we think that this position was best for in this case. But obviously this will vary from patient to patient as the intracochlear morphology varies. So during sheath removal, the electrode needs to be held very steady to avoid any movement and malpositioning of the electrode. So this video from 2015 shows quite a bit of movement of the electrode inside the cochlea, especially in the basal turn. And we can also see the electrode got a bit retracted as well. Then it was back inserted. And a video from 2019 shows sheath removal, but there are no movements of the electrode inside the cochlea, and to prevent any malpositioning. Here we can observe different positions during fluoroscopy of the electrode. Here we can see movement to the lateral wall while trying to insert deeply, and then pullback maneuver where it comes more proximal to the modalis. This second patient, we were trying to insert the electrode deeper inside, but here we can observe very soon a bulging effect of the electrode here in the basal turn of the cochlea, and then quite a lot of movements in the basal turn of the cochlea. And this third patient here, we can see a bit deeper insertion at the tip, but also the bulging effect in the basal turn especially. There is also a risk of intracochlear movement of electrode array during coiling of the lead in the mastoid, especially when there has been done soft sealing. So here we can see electrode array position before and after coiling. So on the left side, there's a fluoroscopy picture showing that the electrode seems to lie more proximal to the modalis. Whereas after coiling and probably a bit deeper insertion, the electrode has moved more laterally in the basal turn, also a bit deeper insertion, but lateral movement. So it is desired to keep the electrode very steady during coiling, as it may cause malpositioning of the electrode inside the cochlea, which is not very obvious to the surgeon if you don't have intraoperative fluoroscopy. So a traumatic insertion and optimal positioning of the slim modular electrode requires training and experience over time. And in our view, intraoperative fluoroscopy can be used to optimize the insertion angle and favorable positioning. Thank you for your attention.